about substituting observation for surgery in patients who show exceptional response to neoadjuvant therapy. Thank you.
Thank you very much, Professor Jessica, for these two excellent talks. Now we shift for discussion. Can I start by questions, me or Dr. Nuran, Dr. Wala, or you wait for audience discussion? I can start by questions.
Oh, you are first.
Okay.
If you have any
I want to ask.
You have any questions?
I want to ask. Yes, I have one question for Professor Jessica. I will ask about the use of color duplex ultrasound in diagnosis of suspicious breast mass or suspicious lymph node. Can you depend on this?
I think the question, well, first, thank you very much for the opportunity to be here. Thank you for the moderators. I think the question was, do I use Doppler ultrasound in assessing breast lesions in assessing lymph nodes? Is that correct?
Yes.
Okay.
Yes, I mean
this. The answer is that we don't really rely on it to say benign versus malignant. We rely much more on morphology, on correlation with mammography, and on any interval change comparison with before. We do use it, of course, in situations where we are doing a biopsy, for example, to try to avoid a large biopsy, particularly in the axilla. We do use it, let's say you have a lesion in the breast, you think it's an intramammary lymph node, you're not sure, and you're looking for the hilar vessels. And we use it when we have, let's say, a hypoechoic region, I'm not sure is a mass or just breast lobule, or if it's a cyst, that helps me say is a solid mass that can be a cancer. So kind of adjunctive reasons, but not so much primary to say benign versus malignant, at least not usually.
So you can depend on Doppler for diagnosis, for differentiation.
I would say definitely you cannot depend on Doppler to say yes cancer or no cancer, but you can help it when you're like, in the middle and just not sure the next step, and you really just need a little push toward one way or the other, then that can be used as in an adjunctive or complementary, additional supplementary fashion.
Okay, thank you. Professor Nuran, if you want to ask any question.
Yes, actually, I have two questions. The first one is about your protocol in your patients that undergo a neoadjuvant chemotherapy. Do you do MRI for all the cases, or you choose just the cases that have dense breast?
Okay, that's a great question. I would say that typically in the United States overall, MRI would be done, and I'm not sure I can say all, but majority of the neoadjuvant cases. That is not the situation at MD Anderson, which is not typical of the United States. I think that has to do with historical reasons at our institution. It's the fact that we have a very vibrant, large, and I would like to say very good ultrasound service in breast, particularly because of our wonderful technologist team, to whom we're so grateful to do that. In the States, most of our breast ultrasound is first done by our technologist. And the other kind of practical thing is that with breast MR, you typically need to get insurance pre-authorization in the United States, and of course contrast, and of course more difficult to biopsy. And since at our institution, we have a lot of patients from outside Houston coming for their care, that tends to make things more difficult in terms of scheduling and just the very practical aspects of evaluation and treatment. So to go back to your question, is that we don't at MD Anderson, but I think that is the case in most of the United States. And I believe that that is a good use of MR, assuming that it can be implemented in your practice.
Thank you very much. My second question quickly is about the camouflage sign that was introduced by Kaiser a few years back. I don't know if you're familiar with it. He said that findings on MRI on the non-contrast images, if you find the tumor bed, but it did not enhance with contrast, this means that there is microscopic tumor present. And if there's no finding on the non-contrast images that means, as well as the post-contrast images, that means that definitely there is no more microscopic tumor. So what's your opinion about this?
Thank you, Dr. Noran. Always asking great questions. I'm familiar with it because, Dr. Kaiser did such amazing work and left such a legend, in breast MR, also with his personality. I don't have clinical experience to answer that question. One is that, as I just mentioned, MR is not that much of a routine part of our practice at MD Anderson. So that's just a fact of what we do. And that I don't think that I have enough. I think that I see something most of the time, even on the pre-con. I haven't gone back to our data to say, what that correlates. And you gave us interesting research ideas, and perhaps we can all work together to do a larger study on that. And the fact that I have a lot of ultrasound in our practice in terms of the neoadjuvant follow-ups. They could be done sometimes every 2 weeks. That's very often. And that's because our patients are in multiple drug trials, different pharmaceutical companies and different therapeutic regimens, so that we get so much ultrasound that I'm going to guess that biases whatever I think about. But certainly going forward is something to keep in mind, and I think it's interesting. I can't answer that question, but I do think it's interesting.
Thank you very much.
Dr. Jessica, I have a lot of questions from our listener.
Sure.
First one we have regarding supraclav. If we have a central hilum and cortical thickening less than 3 millimeters, consider it as pathological or follow-up?
Okay, I'm going to repeat the question. I think you asked about infraclavicular nodes or some nodes.
Supraclav.
Sorry?
Supraclavicular.
Supraclavicular nodes. If
Yes.
it's fatty hilum, can you follow it? Is that the question?
Yes.
Okay, so fatty hilum is always a good sign, but of
Okay.
course you want to look to see if there's cortical thickening, abnormal shape, et cetera, okay? It's a hard question to say yes or no, right? You have to kind of be in there looking at the case. I can tell you that very helpful hints to us in the clinic is symmetry. So let's say your cancer is on one side, the right side, and you see that node that you just described in the supraclavicular region. Look on the left, even though the patient doesn't have cancer there, and see if it looks the same. And if it's symmetric, that goes for the fact that that's just how this patient looks in terms of the nodes. That's benign. And of course, if you have multiple nodes in the supraclavicular, they all look the same, you're leaning toward benign, then multiplicity also, similarity also suggests that it's benign. Is when things kind of stick out as focal, different from the other side, that's when you worry more. But that's kind of a general hint. A lot of it is kind of experience and seeing them. And when you are in doubt, at least initially, I think that an FNA biopsy of the supraclavicular node, we do that fairly frequently with good success, can be part of a practice's regimen. As I have lectured before, I have had the pleasure to lecture before at this conference. We also biopsy internal memory nodes under FNA, which is a totally different story. The supraclavicular node is fairly superficial, and in most of the time, it is fine, technically.
Okay, the same question, but in a case of post MRM, in follow-up, we have a supraclav.
If I have a supraclavicular node, if I think it could be malignant, we biopsy it using FNA. We don't really just follow it because these patients tend to have cancer, right? That's what I'm doing these nodes most of the time. So your oncologist surgeon wants to know, because that's part of the staging that matters. So we tend to don't follow those patients. That's average practice. I wouldn't say never, because sometimes you just can't get to the node because it's very close to the carotid and the jugular. There's all kinds of reasons, but typically the goal is to say possible cancer and therefore biopsy to show one way or the other, or benign, it's fine. Those are the two big care categories that you want to drive your decision tree, because that's how you're going to help your patient, especially a cancer case.
Okay. Follow-up chemotherapy, prefer MR or sono-mammo?
I prefer MR in follow-up neoadjuvant therapy. And I think the studies have shown it's most accurate, and I think that's done in many centers. But of course, that has the challenges that we talked about. IV gadolinium, the cost involved. If I see something I cannot biopsy right away. So mammogram and ultrasound, especially ultrasound, definitely have an important role. If I have to choose, I want all three, but if I have to choose, ultrasound and MR. In theoretical sense, I would choose MR, but in the practical sense, I may choose ultrasound. And ultrasound, again, is primarily what we do at MD Anderson.
Okay. In follow-up by MRI, which matter, pattern of enhancement or size of lesion?
That's another great question, and that's one of the challenges of imaging follow-up. There's not so much standardized. If possible, the functional volume change, which is what was measured in the Akron 657 trial, would be the one I would suggest as the single thing. So that would be more changes in size as opposed to degree of enhancement. Of course, when you have neoadjuvant therapy, most of us have seen those, and the degree of enhancement is also decreased. It's no longer as bright, right? No longer, showing that rapid washout. And that's more of a subjective assessment, though, for me to say, oh yeah, this is being treated and it's responding, but I can't really tell you, is that like a 10% response, or is that like a medium response? Is that like a super response? It's more of a subjective thing. So if I have to say size, functional volume size is what the Akron study shows. Easier said than done, right? That's easier when you have a mass that responds in a concentric pattern. But when you have a non-mass enhancement that responds, let's say, in a scattered pattern, that's trickier, which is why our imaging really good. And of course, I love it because, I, like you, am an imager, but it's not perfect in many ways. And perhaps things like AI, like our last speaker talked about, artificial intelligence, can be used to pick up and also quantitate residual disease.
Thank you. Okay, I have another question. What's the difference between scattered and concentric pattern of response?
What is the difference? The difference is that concentric is much easier for us radiologists, big mass getting smaller, smaller, smaller. The scattered, and at recent RSNA meetings, I've also heard the word dendritic being used, D-E-N-D-R-I-T-I-C, I think I spell it, dendritic, kind of like, the dendrites of neurons, like lines extending. But bottom line of that is a big area, and you get breaking up into smaller little pieces. I don't know of any sort of clinical significance other than the radiology article that's based on research in Japan that I kind of quoted. Concentric response may signal a longer survival for those luminal A cancers. But practically speaking, I don't think there is a difference in terms of the patient management. But the other hand, though, practically speaking, it is more difficult for us radiologists and pathologists to evaluate those disease.
Okay. What about the experience about MRS and diffusion? It has a role in predicting response to a new adjuvant?
Okay, so MRI diffusion, my personal bias at this moment, it doesn't help me clinically. That's not to say it doesn't have a role. That's just to say in my hands right now, I don't really rely on it clinically. I think it's not easy to do technically, of course, requires more time. And there has been Akron trials on that. I can't remember the exact number now, but there's another Akron trial. And it shows that it has a role in the sense that it tells you very similar things as what the dynamic contrast enhanced series shows. And interestingly too, it was best for HER2 positive and triple negative cancers. So I don't want to say no, it's not useful. And the studies show that, yeah, it's possible. I'm just saying that in terms of in the clinical situation, the extra work and technique that you need to go into it, I'm not sure it adds much to my interpretation. When we have doubts, borderline of what it is, we tend to, biopsy as the answer more. Perhaps in the future, when technology gets even better than it is now.
Okay, my last question. If we have multiple pathological axillary nodes, you just clip the most suspicious one?
Okay, so when we have multiple suspicious nodes, do we just clip the most suspicious one? Another great question. I think you're asking if this is a cancer patient, we find, let's say 5 nodes in the axilla. We only biopsy 1, right? Then yes, we just clip that 1 that we biopsy. We don't biopsy 2 or 3 or 4 or 5, okay? You clip the one that has the cancer that you, and not just because the way it looks, but because you had biopsy proof. At our institution, we do FNAs. Some institutions may do core biopsies, okay? And that is called the clipped node, and that's part of the targeted accelerated dissection. And then the next part of the question may be, well, there were 4 other nodes there. You randomly picked one. Why is that one any more significant than the other 4, which you did not biopsy, but it could be cancer? Which question? I think that that's the theory, but the studies in terms of I think that there were ACOSOC trials being done, the American College of Surgeon Oncology Group trials, and those trials, I think it was Z1076 or 1071 trial, shows that when you do that, it works in terms of not having the need to go to full nodal dissection, a low false negative. So this is just how the trial was structured and how it was done, and show that it works, and that's why we follow it in terms of the protocol.
Thank you, Dr. Jessica. I have one question out of our topic. What's your opinion about ultrafast MRI? Is useful like our daily work?
Okay, I think the question is, what do I think about something MRI? I'm sorry, I couldn't quite hear the first word.
Ultrafast MRI.
Ultrafast MRI. Okay, so ultrafast MRI, specific techniques as part of the whole abbreviated MRI, fast MRI movement. A little bit different because you actually have ultrafast techniques, but in that line, yes, I think it's promising. And at MD Anderson, we have proprietary sequences written really by a physicist that's being tried now. Yes, I definitely think it is has a role. It has not have a very, very big role yet in the States, probably because of our whole healthcare structure. How do you charge for it? Can you charge a regular MR? Can you just charge less money? If you charge less money, how much less money? All those things haven't been worked out, and we can't just make up a number in our system. So I would say yes for screening of certain populations, your high-risk populations.
Okay. My final question from your lecture last year, not today. Someone asked about molecular subtype imaging.
Okay, I'm sorry. The question is that there are different molecular subtypes of imaging. What do I think about the imaging of them? Is that the question?
Yes.
Okay, so I think it's exciting that we're learning that imaging can be molecular subtype dependent, right? That's not just mass or calcs and, kind of big picture. And of course, as we understand more about biology of breast cancer, we know that it's not just size. It's not even just lymph node status, but the biology matters so much. And that's why in the most recent edition of the AJCC TNM staging, the 8th edition, that the biological factors, in particular the grade, ER, PR, HER2 status, is actually part of that clinical staging now, instead of just the size of the tumor. So all that's a long about answer to your question about, what do I think? And I think it's cool, it's exciting, because breast imagers have a role. We know that typically the speculated mass, the architectural distortions that are invasive cancers tend to be the the luminode and tend to be lower grade cancers. We know that typically, that triple negatives tend to be that solid mass that's even circumscribed sometimes, right? So we know that. So we know there are, and we talked about ACRIN 6657 being better for the HER2 and the triple negative in terms of response. So we know that imaging is subtype dependent in many senses and can pick out differences. So that's a starting point. And perhaps that, I don't think at this time it replaces pathology in any way. Of course, you still need to do the biopsy and get the ER, PR, HER2 markers. But maybe in the future, with things like diffusion, maybe different techniques, we can use imaging to maybe not replace pathology, because that's a big goal, but at least to supplement it or to predict it or to have some role in the clinical paradigm, which would be less invasive, and that would be very exciting. So I think we're the early part of recognizing the importance of that.
Thank you, Dr. Jessica, for this wonderful lecture. Dr. Mohammed.
Thank you very much, Professor Jessica, for this appreciated your chairing in the conference and these excellent lectures. I want to thank all the organizing committee, Professor Rasha, and all the team of organization. And you proved that the online meeting is very beneficial and very important. And we will be happy to attend all online meeting better than physical attendance later on. I want to thank Dr. Ran for her sharing with her in this session, and Dr. Wala for her effort. And I want to thank all the attendees, and I hope to see you many times in next meeting. Thank
And
you.
if I may,
شكرا يا دكتور محمد. شكرا.
thank you. And if I may just say quickly that I also want to thank everybody, always wonderful colleagues, and we learned so much from all of our international colleagues. And that to put a little plug, that Society of Breast Imaging that I represent is also having a virtual meeting in April of this year. And please contact me with any questions. And I'm going to say, Dr. Rasha Kamal will also help me. Dr. Noran will help me in that. Thank you.
Okay. Jessica, just keep Dr. Mohammed خليكوا. We are going to take a group photo now, I think. Iman,
Yes,
I
will just end the streaming first, and then we will be together afterwards. Thank you, Dr. Jessica. Thank you for your invitation. And thanks everybody for attending our sessions. We had over 1,000 interactions from all over the world during our radiology course in these 2 days of presentations and sessions. Thanks to all international speakers and national speakers who joined us in making this course a success. Dear participants, you will be receiving a direct certificate of attendance of these sessions directly to your pre-registered email during the 2 weeks. And in case you had any trouble, please feel free to directly contact the organizer of the conference through the bgicc.net website. Now you are all invited to join the main hall streaming of the BGICS multidisciplinary recommendation in luminal breast cancer management. It's a very interesting and interactive international consensus where all the international and the national expertise will be voting on the recommendation for a very controversial topics on luminal breast cancer management. Thank you all again, and this is the end of the streaming of the radiology course. Thank you all, and see you next year. Thank you.
Thank you. Be well.
Thank you.
Thank
Yes,
you.
thank you.
Very much. Bye now.
Thank you, Miss.
Yes.